collaboration with our funder, the Department of Mental Health, engaged in a strategic assessment and strategic plan process. We engaged DMA Health Strategies, a consulting firm that specializes in behavioral health, to help us with the strategic assessment. Through a number of key stakeholder interviews and an enormous amount of data analysis, we dug into the successes and challenges of MCPAP and what we should be doing moving forward. Many of you on the phone may have actually been interviewed as part of this process. The assessment actually led to developing a strategic plan and subsequently a request for information from key stakeholders on redesign. Completed that process with a request for proposals and selected the new teams to services for MCPAP 2.0, all which you are very familiar with. We have all of our same sites providing services as we did previously. We're very excited about that. So, successes that were identified in this process that MCPAP is a very innovative, groundbreaking solution, and as we've mentioned previously, it's been replicated across the country in many states. That MCPAP is a highly regarded solution to the problem of the scarcity of child psychiatry, and it has been included in the 21st Century Cures Act, which signed President Obama on Tuesday. So a lot of attention, and the success is widely known across the country. The assessment also uncovered some challenges for MCPAP as well. These include misperceptions about our care coordination process. We got feedback on some of our provider experience surveys, and anecdotally, that families were not actually following through on the and there was an expectation that we were able to make them do that. Unfortunately, that's not the case. So you'll hear more in a little while about how we're changing our resource and referral process moving forward. There were also some unrealistic expectations about MCPAP's ability to fix all the problems with the behavioral health system in Massachusetts. So addressed and clarified our role in the children's behavioral health system, which you'll also hear about moving forward. And then there's some performance improvement recommendations. And because each of you is only enrolled with one team, you're not aware that there was considerable variation across teams, which would like moving forward to standardize more often. All this was happening in the context of a changing healthcare environment. Very familiar with changes, the rise of ACOs, behavioral health integration, practices integrating with different physician networks and ACOs and health systems, all of which really change the way that you're practicing. And also becoming certified as patient-centered medical homes. DMA Health Strategies came up with a number of recommendations, many more recommendations than we could ever implement, and this led us to refine our mission, to clear a role within the children's behavioral health care system, and to make enhancements to the model that more effectively respond to today's healthcare environment. Over to Dr. Sarvat to go over some of these changes and how you will experience them as an enrolled practice of MCPAP.
Oh, thank you very much, Marcy, and thanks everybody for being here and for involvement in our program over the years. Mary, could you advance the slide? Okay, so I'm going to start by just really clarifying and articulating the overall mission of MCPAP. And I guess the point here is just that MCPAP is not changing significantly in terms of its mission and the core services that are being provided, or we're eliminating any core services. The MCPAP remains as really essentially a primary care facing program. I mean, it's for you. It's for primary care providers. It's really predicated on the idea that behavioral health and psychiatry is really part of primary care, and that primary care providers, they really need a collaborative relationship with specialists. And really this is something that is a principle that's really part of the medical home model. It's applicable to many other specialists, but I guess we acknowledge that in psychiatry and behavioral health's been carved out for many years historically, and so primary care docs and providers have not enjoyed the same kind of collegial relationship with psychiatrists and mental health providers as they should and as they have with other specialists. And so it's really a program that creates these relationships and tries to develop them. And through these relationships that we're trying to provide consultation and education and to try to improve the capacity of primary care providers to do as much as they can to treat mental illness in the population. Okay, so next slide, Mary. So I also want to reiterate some of the specific goals, and some of these are relatively new. So first of all, the face-to-face assessments, that's the same, and we're going to go through more of the specific things that are changing. So we're still going to provide expedited face-to-face assessments for PCPs who need them. We're going to try to maintain this continuity of a relationship with PAP child psychiatrists over time, and really try to have more shared care, really, where we're kind of working with you and caring for your patients collaboratively. So we're anticipating that there would be more return consultations and phone calls about the same patient so that we can really be with you as your patient over time. We're going to become more data-driven as a program, and we're going to actually help to become more data-driven in terms of trying to make a transition towards more measurement-based care, which is a part of what we've learned to be most effective, actually, for not just for primary care providers, but also for psychiatrists. The field of psychiatry has always been nebulous, and sometimes there's been just this way in which we haven't really made ourselves accountable for seeing how patients are doing over time, and so we're trying to address that and improve that. As a program, we're going to continue to maintain working relationships with the whole healthcare system, with healthcare reform leaders in the state, with networks of care, with payers, with physician organizations, because we realize that MCPAP is really not, it doesn't stand alone. It's really part of a system, and that's certainly true of primary care practices. We'd like to be kind of like the eyes and ears of what's going on the ground in the mental health system. We can't solve the problems in the mental health system. There are all kinds of network inadequacies. There are problems with hospitals discharging patients without good care plans, and we're in charge of those hospitals, but we feel that we have a responsibility as being kind of at the nexus of all these systems to be able to collect data and report back to different kinds of parties who are responsible for these things, and really advocate for trying to make things better, again, without having the authority to, as a program, fix everything directly. Next slide, Mary. There's actually a term it's a little bit confusing, but there's a term that's called the collaborative care model. And we've always felt that our program was a collaborative care program in the sense that we try to collaborate with primary care providers. There is this so-called collaborative care model, which is actually based on a program that was developed at the University of Washington called the IMPACT program. And that's actually an organized model for helping care for patients in the primary care setting using embedded therapists, collaborating psychiatrists, use of registries, and we're actually hoping ultimately to be able to promote the development of these kinds of models of care by helping primary care practices to learn how to make use of these integrated behavioral health providers and helping them to track patients and practices using registries and really help you guys to coordinate care of those patients and providing consultation as needed. And so we're trying to adopt that model. It's a fairly specific model, but we want to take some of the core principles and try to move it into the of the private care systems in the state. Number 7, we actually expect that practices are going to be developing different kinds of internal resources as they move towards becoming medical homes. Many practices are already medical homes or certified, and the whole field of primary care is moving towards really developing this medical home model, and part of that involves, network membership and participation in larger networks so that you can have economies of scale to be able to obtain more resources. And so I guess the point here is that we're not trying to replace the resources or be an alternative source of doing all the same things that medical homes are supposed to do, like care coordination, for example, but we're trying to support that and trying to complement that by providing the expert consultation and teaching practice resources or care coordinators or referral specialists in practices how to do it for mental health, which is different from things, as we all know. Number 8, we actually are taking, 8 is part of a larger story that we're really trying to increase the emphasis on QI in MCPAP. And so one element of that is try to help practices to adopt or really to implement clinical practice guidelines in mental health. And so there are best practices. We've given clinical conversations about some of these, and we have some of these on our website, but we're actually going to be developing a set of MCPAP clinical practice guidelines for the major areas of pediatric mental health for primary care, and we're going to teach to those guidelines, and we're going to consult with reference to those guidelines to try to help practices to be able to incorporate those guidelines into practice. 9, we'll be talking a little bit more about this, but that we're changing our way in which we provide care coordination, and we're actually not calling it care coordination anymore. We're calling it resource and referral, and that presumes that practices will be owning that care coordination piece, but we're going to be helping with that in our way. And so we're going to be trying to help practices develop processes at the practice level for being able to track their patients over time. So we answer a question about a patient with depression, for example, and we make a recommendation or suggest, that you make a certain kind of referral or begin a certain kind of treatment. And we all know that mental health problems are not single episode illnesses that get better like a URI or something like that we have to acknowledge that this is a chronic health issue and that the patients have to really be tracked over time. There has to be a treatment plan that's continuous for those patients. And so we're going to help practices to adopt that model of care as opposed to the single episode kind of thing. We're going to do something and then hope it gets better and then see what happens kind of thing. That's not that people are doing that, but that tends to be something that happens when there isn't kind of a good plan in place. And then finally, as Marcy mentioned, there has been a lot of inconsistency, and we would like to be able to have MCPAP be MCPAP, wherever you are, and in some ways, having a more consistent approach to providing MCPAP across the teams is important for that kind of reliability in a sense. Next slide, Mary. So this is the easy part. So what's not changing? All the institutions that have been in MCPAP and have been providing MCPAP services over time are still going to be doing that. So we have reconfigured our teams, but players are pretty much the same on an institutional level. Some of the teams have gotten a little bit smaller and tighter, so the sites have gotten a little smaller, so that there may be a slight decrease in the number of providers. But the institutions are the same. Core services are the same in terms of face-to-face consultation, telephone consultation. Response time is the same, that we're making a commitment and being accountable to responding within 30 minutes to record telephone consultations. And hours of operation are the same. Now, Mary? It's a significant difference that in the past, as people probably know, that we've had six teams, and we've decided to consolidate the teams to create 3. And as you can see on this slide, we have the West Central team, which is a joint team operated by Bay State and UMass Medical School. The region is divided into 2 sectors, the north and the south, and so there's basically a eastern team that's really made up of 2 subdivisions, and one subdivision of the eastern team is Boston North, which is made up of Mass General and North Shore Medical Center, and Boston South, made up of Boston Children's, Tufts, and McLean Southeast. You see there's a separate call center hotline number for each one, and every practice will know who their team is. Sometimes it's relatively self-evident in the West and the Central. Largely, there are some practices on the eastern border of the Central region that may be relating to either the Boston North or the Boston South team, but usually before we go live with our new plan, there will definitely be and really outreach to practices so that no one will have any ambiguity as to who their team is going forward. Slide. That the reason for going from 6 to 3 teams will become more apparent as we go on in the webinar. But one of the main reasons is that we wanted to be able to have a dedicated child psychiatrist who's on the line for the line at any given shift. And we felt like if we consolidated those call centers, that we would be able to really justify this dedicated presence of a child psychiatrist because it would presume that there would be a call volume, and it would give us a chance to ensure that people are able to focus on that particular task. We'd have more reliable response times, and also we would be able to free up another psychiatrist to do the face-to-face assessments and to do some additional activities that you'll hear about shortly. So I think I mentioned this in this slide here about the fact that and Marcy talked about this, the fact that whole sort of process of pediatric primary care is changing, not everywhere, but there's this process of change going on that seems to be really very continuous. And a big thing is really developing patient-centered medical homes and integrated care and network formation. And so that's one of the main reasons for the change in the MCPAP 2.0 redesign. Next slide, Mary. So MCPAP is that MCPAP has always been, it's been somewhat a firehouse model, as we said. That we set up this program and we put a number and we say, call us if you need us. And so we've decided that we would like to be more of a proactive program where we're sort of pushing out what we do and not just assuming that people who need us will call us and they'll get the help that they need. And we found that there's been fairly significant variability in how much we are utilized from practice to practice. There are some practices that call us every day or multiple times a day, and there's some providers who we feel like we're kind of working with them throughout their day, and we're kind of right there with them. And there are other practices that hardly ever call us. There are some practices that do a lot of behavioral health and primary care, and they're kind of more sophisticated, with that, and they have more providers who are interested in that, and they have efficient process of screening and referral, and then other practices that every time a behavioral health patient comes in with a significant problem, it's kind of like a mini crisis, and so we would like to really help practices to really become adept at providing mental health and primary care, and many of the practices who don't call us for much are the ones who need more help. So it's in some ways it's kind of an ironic sense that we're providing more help to the practices that don't necessarily need as much help, and we're not helping the ones that do. And so again, I mentioned that we're putting out these practice guidelines, and we're going to be providing. I've hinted, and I'll talk more about this now, that we're going to be actually providing training and consultation practices. That's really the third, actually the fourth MCPAP function. So we've always talked about three functions of MCPAP. We've talked about telephone consultation, face-to-face consultation, and we used to say care coordination. Now we call it resource and referral. The fourth practice of MCPAP is really the what we call a practice liaison function, where we're trying to give every practice a child psychiatrist who is point person to help that practice to be able to move on a continuum and to meet their own goals. And we're not saying that every practice has to be the same. We're trying to help the practices to define what they want to become in terms of this mental health business, and then help them move along towards their goal of becoming more integrated when it comes to mental health and primary care. Next slide, Mary. So in the redesign, we'll have 2 child psychiatrists for every team, and we reorganized, but we didn't have any increase in funding. So we're pretty much each team used to have a child psychiatrist FTE for 6, and now we have 3 teams, and each of the 3 teams has 2 child psychiatrists who are on duty at any given time, and that allows us to be more flexible and really dedicate our attention to the telephone. And so with the other child psychiatrist, there is that role. There's one on the phone, and then the other child psychiatrist is either doing face-to-face consults or doing outreach activities to practices, to really educational and training and teaching activities. Some of the teaching activities, by the way, might be webinars like this, smaller webinars for practice. It could be consultation, peer consultation groups, could be trainings for practices, be going out and doing academic detailing. It could be trying to arrange for experts in specific areas like development of registries or specific areas like screening. We have specialized consultants who are available to come out to practices, but your child psychiatrist liaison, the person who's the point person to try to help identify those goals and help to direct the resources to practices that they need. So the column here, resource and referral, which we should talk about a little bit more in depth now. So I just mentioned briefly that we changed the name from care coordination to resource and referral because we didn't want to create any confusion about the fact that practices need to be owning care coordination in a sense in order to really be a medical home. It's not one of those things that can be outsourced to a centralized kind of geographically based program. It has to be really embedded in the fabric of practice, really within the medical home model, because care coordination is so foundational to the medical home. So we're the resource and referral experts in a sense, and our teams have people who we have used to call care coordinators, now we call resource and referral specialists, who will do types of service. One is or providing information to practices to really help practices to be able to navigate and make their own referrals, giving them information of the kinds of referrals that are possible and some of the rules that there are, and to try to lend our experience to practices without doing it for you necessarily. And then the other kind of resource and referral, which is still available, which is not different from what we've done before, is we're actually going and making appointments. We're helping families directly to get appointments. So we'll call families and work with them, and we'll try to connect them with services and try to help them actually get the real appointment. And because that is a fairly labor-intensive process, then we're trying to limit it to patients who are higher risk patients. So whether they're higher risk because they have dangerous kinds of symptoms, or they're higher risk because they've tried to get services in the past before and they haven't been able to, and there are barriers that have been difficult for them to overcome, that we're likely to provide that kind of direct assistance to families if they really need it. But we would like to also really emphasize the need for practices to have their own care coordination and referral tracking, and so we want to do more and more of this, resource and referral consultation where we're giving information and teaching people within your practice how to do it. So those are the two kinds of resource and referral. That's different because, past or currently, I think there's been an assumption that we'll go and call families whenever we're asked to do that. And we know that we can't do that. We don't have enough resources to do it for everyone. And we want more of you to be utilizing that service, which would be unsustainable if we continue to do it the same way. And so that's why we're changing that process. And then the third column is what I mentioned before about being the eyes and ears on the ground in terms of what's happening in the mental health system and what's available, what's not available, what's working, what's not working, and then taking on that responsibility to be advocating for solutions to different problems that pediatricians face when they're trying to address the needs of patients in the primary care setting. Next slide. So this is the last one, and so what's it going to feel like? I mean, you're going to tell us what you're going to experience, but we're expecting and hoping that what you'll find is that there is a slightly larger group of psychiatrists who are going to be answering the phone when you call the line because the teams are consolidated, but there won't be too many more because we've limited the number of providers for each team so that they don't have too many for you to get to know. So we really want there to be, it's still a relationship kind of program where it's really about developing these collaborative relationships, and so there'll be a larger group for each consolidated team, but not too many. So that's one thing that you'll probably notice. There will be some new relationships, people you haven't talked to before, and you'll get to know them, and they'll be serving you. And all, obviously people that have great reputations and who are personable and really eager to help you. Every practice will have a liaison. So a child psychiatrist will be assigned to every practice, and if your practice is part of a network, like CPOC, for example, a big network that has really very robust programmatic approach to integrated behavioral health with embedded providers being provided to practices like that, that liaison for PPOC practices will be someone who's from the children's. So there is that connection to the programmatic approach to behavioral health integration for that particular network, and other networks that are liaison assignments, where we're assigning child psychiatrists to be your liaison, that we're going to try to match practices that are part of networks to psychiatrist liaisons who are connected to those programmatic approaches within networks. You'll notice, talk about clinical guidelines. The clinical guidelines are in development, and so that's going to be our task over the first year of the MCPAP 2.0 is really to have a set of clinical practice guidelines that we are adopting as a program, and so you'll be hearing about those all the time. That you'll hear about them when you call the phone and get telephone consultation. You'll hear about them in the letters that are sent to you when we do face-to-face consultations. You'll hear about them from your practice liaisons when they're providing trainings. You'll hear about them on the clinical conversations, webinars. And then you'll experience the outreach activities from your liaison, which we talked about. And then when you have people within your practice who are identified as being part of this care coordination process, that those people will be receiving education from us, that we're going to be trying to provide education to those providers to teach them how to navigate the behavioral health system. So I think that's kind of the gist of what you'll notice in terms of being different when MCPAP starts, when MCPAP 2.0 starts in January. And so I think I'll stop there, and we do have some time for questions, and Lucy can help answer them too.
We don't have any questions yet, so please type in the chat box or raise your hand, and we'll be able to answer any questions or comments are fine, concerns as well. I would like to add.
See, looks like Michael Posner typed a question, which I see on my screen. Says, how will schools with counseling systems, nurses, school physicians, and serve patients whose primary care PCPs are less involved with MCPAP behavioral health, involved in the reentry to school of hospitalized students on discharge? So one thing is that we schools have physicians and nurses who are really involved in providing school-based health services. Those school-based health resources are really part of MCPAP, and I think that we can provide consultation to them. But I guess that might not be quite the question. It's really how will they involved in the reentry to school of hospitalized students on discharge, and I think that this is particularly for the question for PCPs who are less involved with PAP. So if the patient's PCP is not involved in MCPAP, and then the school needs help to re-enter those kids into the system, then it's hard. It would be hard for us to help with that without someone advocating for the patient And so I guess the school provider, that if we really try to build those relationships with those school-based mental health, school-based health providers, that we can help those kids and answer questions for them and try to provide consultation for them. But I guess the other answer to the question I would say is that they're really targeting, the question is predicated on this notion that some PCPs are not very involved in MCPAP, and I guess the answer I would have is that we're kind of targeting those practices more and more with MCPAP 2.0. So hopefully we can do more outreach to some of those practices that aren't involved in MCPAP and to try to get them involved. But I do think that is, the case that Michael proposes or presents is a very challenging case that really kind of reflects the need for us to do more outreach, because there are a lot of kids who slip through the cracks because not everybody is involved in utilizing all the services that are available to them. There's another question from Jennifer Knight. When do they just go into effect, and will the McLean Southeast still be located in the Middleborough area?
To that, Barry. Go ahead.
No, please go ahead.
So the teams the change in teams will be as of January 3rd. The other changes that we've been talking about are going to happen in sort of an evolutionary process over time. So to answer the specific question, yes, McLean Southeast will still be Middleborough. All the institutions that you are familiar with will remain in the same locations. We will be adding Boston Children's Hospital as another site for face-to-face assessments. The other thing that you should know is that face-to-face assessments will be able to take place at any of our sites based on family preference and convenience. We'll be moving forward during the year at some point implementing telepsychiatry for our face-to-face assessments. We've been piloting that out at the Bay State site, and you'll hear more about that. I don't want to overwhelm people with too much information, but to reassure you that all of the same sites will be able and will be even more flexible with where a face-to-face assessment can take place. You are all going to be receiving a package next week from us that will include a letter with your team assignment and all of this information in written. Some new brochures. We've revised our brochure to reflect the changes, and some scratch pads that have the number that your practice will need to call to access MCPAP, so that you have that readily available, and team name. Most practices, not all, but most practices won't see any change in their team assignment. You'll have your call group, as Barry explained, but for your liaison, it will be network specific. And if you receive your badge and your assignment and you have any questions or concerns, feel free to email us at mcpap@beaconhealthoptions.com, or you can call me directly at 617-350-1978, and this information will be on the letter that you receive. And absolutely feel free to call if you have any questions or concerns. Do we have a question?
Yeah, we have another question. Do you have ideas for financing care coordination as that large and complex issue not currently addressed? Do you think mental health agencies should do or PCP?
Go ahead.
We can both answer that. It is not necessarily clear and concrete, but I guess there's how do practices finance medical homes? That there are different kinds of incentives and value-based payments and kind of infrastructure development funding streams that are available for medical home development. A lot of times those funding streams are going to large networks rather than individual practices. Whether it's value-based payment, you can't really do value-based payment without being part of a network. It's hard because you don't have enough covered lives, and that's one of the big challenges. Some networks like PPOC, for example, are actually providing funds to practices to support the use of embedded behavioral health providers. So care coordination is different from this notion of embedded behavioral health providers, and so the embedded providers are sometimes able to do some care coordination, and so sometimes if you have a care coordinator in your practice that is really part of the medical home, that person might not have any skill in terms of doing behavioral health, and that's kind of where we come in. But I guess the answer to the question is that that if you're getting care coordination from an embedded behavioral health provider, there still is some fee-for-service revenue that can be generated. We know that the more that the practice is depending upon the fee-for-service revenue from an embedded provider, the less the provider is able to truly collaborate with the practice. So that's always been a challenge. But the revenue can partly offset the cost of the embedded behavioral health provider. And then, a true care coordinator that's really not doing clinical work in the practice, that's not going to generate any fee-for-service revenue because that's really not available through the current mechanisms. And the only hope for financing those things is really by getting a piece of value-based payment for meeting quality goals and for reducing costs, which we all know is very hard to do in pediatrics. And then I guess finally, there's a big Medicaid ACO project. Again, requires that you be part of a network, but there is a process for certified community behavioral health organizations to funding through the state that's from the federal government for infrastructure development, and that mechanism is to support the development of infrastructure, including caregivers, and so that's something that's on the horizon. But again, I think the common theme is that there's not much financing and funding stream available for this for single practices. That it's being part of a network puts us in a much better position to be able to garner those kinds of revenue streams for care coordination. Margaret?
Yeah, I want to address the other part of the question, where does care coordination belong? And we believe it belongs in the primary care practice for two reasons. First of all, if you are certified as a patient medical home or you're going towards that goal, that's a requirement. But the reason it's a requirement is because that's where it's best done. You all have a longitudinal relationship with the majority of your patients. So if not following through on a referral, well, you should be having some kind of tracking system to monitor that. But also, they'll come back in at some point, whether for a sick visit or an annual checkup, and you'll be able to, follow up with them and find out what's happening. So either proactively or reactively in a position to do that, and most importantly, patients trust you as their pediatrician or, pediatric primary care provider, and they don't know an outside person, such as MCPAP or who else might be doing it outside of your practice. So it's really best done within the practice. It creates a better chance that the patient's going to follow through and more opportunity for actually following up. I didn't at the beginning, or when we talked about why we changed this, we did a 2-year initiative following up the referrals that we were making for your patients. And we found that 50% of the time we couldn't even get a hold of them. I'm sure you're all familiar with that phenomenon. Anybody that does this kind of work understands that happens. Even for the ones that we were able to connect with, a good portion of them we're not following through. And we truly believe that you're in a better position to encourage them, and through your relationship, help them understand the importance of that.
One additional point I would make to what Marcy said is that the degree of hands-on care coordination that a practice does different depending upon the severity of the kid's mental health problem. So if you have a kid who has a severe, persistent mental illness and a high level of disability, then it is appropriate for you to really expect that care coordination to largely be done within the mental health system. So CBHI programs and therapists, who are taking care of the patient really should be held responsible for doing a lot of the hands-on care coordination. That doesn't mean that the pediatrician doesn't need to know what they're doing and need to kind of monitor that and receive information and keep it in mind. But a lot of it is delegated. For kids who have more mild to moderate mental illness, then that care coordination, even though it's not as scary and intensive of a disease, it still has significant impact and morbidity. So there really is a need for the practice to kind of own that notion of saying this is one of my problems on my problem list, and I have to keep it in mind, and I have to be aware of what's going on with that kid and what the treatment is, and so that is practice-based care coordination. And as Marcy said, that MCPAP is not in a good position to be able to do that well, since we don't have the relationship with the family that you do, and because we're not as accessible and we're further away from the family and all that kind of stuff. Sir, I think there might be another question on my list here. So I have a question here. It says, I'm a physician working in a system that has an integrated approach to mental health and primary care. Will the consultation and education I get from MCPAP be consistent with what my system is providing? And the answer to that is yes. We have designed our practice consultation program to really link up with the pragmatic approaches to behavioral health integration that is being provided through network. So we're trying to complement that, and we're trying to reinforce it. We're not trying to make everybody confused and set up a competing kind of system. So question, which I think might be related, we are the PPOC and have a cohesive care coordination flow in place. Wonderful. Working care presents the big issue after referring to MCPAP because there are so few psychiatrists to refer to for medication management. Are you planning to help? And I guess yes, to some extent. That I think the point I would make is, as I said in the beginning, is that we don't have the power and the authority to create more community mental health resources in the system. So the way that we would help is that we would be helping to advocate for network adequacy throughout the regions, and so when we become aware that a patient needs to have a specialist that really is more complicated than would be appropriate primary care provider to be treating with medication, but there's no psychiatrists out there, then we are planning to be collecting data about that and being advocates so that we can use whatever leverage we have and our connections to the Department of Mental Health and to the state government and maybe even to Insurance Commission to say, look, we need more child psychiatrists in the Southeast, and we are hoping that some leverage can be placed also on institutions who are leaders in healthcare delivery in various regions to say, look, you don't have psychiatrists, you don't have any psychiatric clinics in your institution, serve community, and what's up with that? And because I think there are numerous stakeholders that really have some responsibility here. So there's insurance companies, there's institutions, and so we're planning to do what we can to advocate for these things. But in the end, we all know that the Christian is left holding the bag, and so we're not happy about that. But we kind of know that pediatricians do what they can, and so the other way that we help is that we're going to help the pediatricians to do what they can. So if you're working outside of your scope of practice, maybe need to do more consultation, and seeing the patient, a little bit more, in terms of follow-up consults and more kind of shared care, configurations where you're prescribing and we're doing a consult, and then you might say, okay, well, this is what I did, and I think Michael Posner knows that we've done this with him in the past, because he was asked another question earlier. What do I do next? This is what happened, and so we do return consults and try to stick with you. And that's the other way that we can help with that.
I don't have any more questions. Gary, do you have any more?
I don't see any others.
Well, we can end a little early. If folks do have questions or concerns, again, feel free to email us at mcpap@beaconhealthoptions.com or call me directly at 617-350-1978. On the lookout for your package to arrive next week. Thank you for joining us at this early hour, and we hope you have a wonderful holiday season. Mary has a few closing remarks.
Just to remind everybody that you will be getting a brief survey after this. If you could please take a few minutes to fill that out, that would be greatly appreciated. And again, this recording will be available on our website. Thank you very much.